So, good morning everyone. Myself, Dr. Devangi Dwivedi. Today, I will tell you about oral lichen planus. First, coming to the introduction. So, it is a common mucocutaneous disease. Mucocutaneous means involving the skin and the oral mucous membrane. It was first described by Wilson in 1869, and about 0.5 to 1% of the world's population is affected by oral lichen planus. The condition can affect either the skin or mucosa, or in some cases, both can be affected. So it is commonly seen bilaterally. White striations, papules, plaques on the buccal mucosa, tongue, and gingiva are some of the sites or where lichen planus is seen. Erythema, erosions, and blisters may or may not be present. The involvement of the oral mucous membrane is so frequent and accompanies or precedes the appearance of lesions on the skin and genital mucous membrane. So the overall prevalence of oral lichen planus among Indians was 1.5%. It was highest 3.7% in those people with mixed oral habits and lowest in non-users of tobacco. So mainly tobacco is the etiological factor. The annual age-adjusted incidence rate was 2.5 and 2.5 per thousand among men and women respectively. It was given by Bosley et al. In 1979. The relative risk for oral lichen planus was highest, that is 13.7 among those who smoked and chewed tobacco. Next, coming to the etiology. So it is a T-cell mediated autoimmune disease in which the CD8 plus T cells, they trigger the apoptosis of oral epithelial cells. Apoptosis is the procedure of the death of the cells. The precise cause of OLP is still not known. The CD8 plus lesional T cells may recognize an antigen associated with the major histocompatibility complex. We can say MHC class 1 on keratinocytes. After antigen recognition and activation, CD8 plus cytotoxic T cells may trigger keratinocyte apoptosis. After that, activated CD8 plus T cells, possibly the keratinocytes, may release cytokines that attract additional lymphocytes into the developing lesion. The lichen planus antigen is unknown, although it may be a cell peptide. The expression or unmasking of the lichen planus antigen may be induced by drugs. Here we call it as lichenoid drug reaction, contact allergens in dental restorative materials or toothpaste, mechanical trauma, which is referred to as Koebner phenomena, viral infection, or unidentified agents. It is interesting to note that the disease is seldom seen in carefree persons. The nervous, high-strung person is almost invariably the one in whom the condition develops. So the stress factor is associated with this disease. The course of the disease is long, from months to several years, frequently undergoing periods of remission followed by exacerbations, which often correspond to periods of emotional upset, overwork, anxiety, or some form of mental strain. Other causes suggested include traumatism, since outbreaks often developed along scratch lines, malnutrition, and infection. Now let's see what is Greenspan syndrome. So it is a association of three things. What are those? Lichen planus, diabetes mellitus, and vascular hypertension. Next, coming to the clinical features of oral lichen planus. So here the female is to male ratio is of 1.4:1. Adults older than 40 years of age are most commonly affected. The skin lesions of lichen planus appear as small, angular, flat-topped papules only a few millimeters in diameter. These may be discrete or gradually coalesce into larger plaques, each of which is covered by a fine, glistening scale. The papules are sharply demarcated from the surrounding skin. Early in the course of the disease, the lesions appear red, but they soon take on a reddish, purple, or violaceous hue. Later on, a dirty brownish color develops. The center of the papule may be slightly umbilicated. Its surface is covered by characteristic very fine grayish white lines. called becomes striae. So this word is very important. It is asked very often. What becomes striae? So the lesion may occur anywhere on the skin surface, but usually are distributed in a bilaterally involving the both the right and the left buccal mucosa symmetrically in a symmetric pattern, most often on the flexor surfaces of the wrist and forearms, the inner aspect of the knees and thighs, the trunk, and especially the sacral area. The face frequently remains uninvolved. In chronic cases, hypertrophic plaques may develop, especially over the fins. The primary symptom of lichen planus is a severe pruritus that may be intolerable. In patients with OLP, scalp involvement and nail involvement is rare. Next, coming to the oral manifestations. So the majority of patients with dermal lichen planus have associated oral lesions of the disease according to the study of Schickler and McCarthy. So in oral cavity, the classic features seen are radiating white or gray, velvety, thread-like papules in a linear, annular, or retiform arrangement, forming typical lacy reticular patches, rings and streaks over the buccal mucosa and to a lesser extent on the lips, tongue, and palate. So it was reported by Schickler and McCarthy, the distribution of oral lesions, buccal mucosa 80%, tongue 65%, lips 20%, gingiva, floor of mouth and palate, that was less than 10%. So a very characteristic feature, burning sensation was involved in oral lichen planus. So vesicle and bullae formation has been reported in oral lesion of lichen planus, but this is not a common finding, and the diagnosis of lichen planus from the clinical appearance of the lesions is extremely difficult. So this form has been referred to as bullous form. Next, what is erosive lichen planus? So atrophic areas with central ulceration of varying degrees is seen with symptoms of pain and burning sensation. This type of lichen planus is referred as erosive lichen planus. Then the most common type which has to be remembered is reticular lichen planus. It is seen mostly on posterior buccal mucosa and occurs bilaterally. The characteristic pattern, as I've already told you, interlacing white lines becomes striae is observed here. Here we can see the buccal mucosa. These are the white lines. An atrophic form of lichen planus is also seen. It appears clinically as smooth, red, poorly defined areas, often but not always with peripheral striae evident. The term chronic desquamative gingivitis was at once used to describe a red, diffuse, painful condition of the gingiva, usually found in post-menopausal women and generally quite refractory to therapy. It is now generally accepted that this is not an entity but represent a variety of conditions, including the oral manifestations of several dermatological diseases, one of which is lichen planus. Then a hypertrophic form have also been reported. It appears as a well-circumscribed elevated white lesion resembling leukoplakia. Next, we come to lichenoid lesions. What are they? These are the lesions which are caused by a variety of drugs. And what are those drugs involved? Non-steroidal anti-inflammatory drugs, sulfonylureas, anti-malarials, beta blockers, and some angiotensin converting enzyme inhibitors are involved in such lesions. An important factor which distinguishes lichenoid reaction from lichen planus is its atypical location and absence of bilateral occurrence. So it is making a difference here. There is no specific test to diagnose lichenoid reaction. The widely accepted criteria is based on the observation of disappearance of the lesions after withdrawal of triggering agent and recurrence of the lesions when it is reintroduced. Though histologically, lichenoid reaction has superficial resemblance to lichen planus, there are noticeable differences. What are they? The inflammatory infiltrated diffuse and extends deeper into lamina propria, that is the connective tissue, unlike the sharp band of infiltration seen in lichen planus. Inflammatory infiltrate consists of plasma cell and eosinophils. Increased number of shivered bodies may be present in leukocyte reaction. A perivascular chronic inflammatory cell infiltrate is seen here. Proliferative varicose leukoplakia is often seen. It is an unusual form of leukoplakia. So it occurs most commonly in older female patients and is not associated with tobacco users. Microscopically, it exhibits epithelial dysplasia with a band-like inflammatory infiltrate, which on low power can mimic lichen planus, and here it is known as leukocyte dysplasia. So identification and elimination of triggering factor, it play a major role in the management of leukocyte reaction. Leukocyte lesions can take many months or it may take longer to resolve. The malignant transformation rate is reportedly higher in oral leukocyte lesions, which do not have all the typical clinical and histologic features of oral lichen planus. Now, next we come to the histopathology. So, the features of lichen planus, which are seen are varying degrees of orthokeratosis and parakeratosis may be present on the surface of epithelium, depending on whether the biopsy specimen is taken from an erosive or reticular lesion. The thickness of the spinous layer can also vary. The retiridges may be present or hypertrophic, and this is a very important feature. Sawtooth shape like retiridges are seen in lichen planus. Then there are destruction of the basal cell layer, which is also known as hydropic degeneration. Then band-like infiltration of predominantly T cell is seen. So this is important here. The inflammatory infiltrate is in the form of band, and it is not distributed among the whole connective tissue. Degenerating keratinocytes may be seen in the area of epithelium and connective tissue interface and have been termed colloid, cytoid, hyaline, or shivered bodies. Degeneration of the basal keratinocytes and disruption of the anchoring elements of epithelial basement membrane and basal keratinocytes. It weakens the epithelial connective tissue interface. As a result, because of this weakening, histologic clefts, and these are known as Mac-Joseph spaces, they are seen. B cell and plasma cells are uncommon findings. Here we can, the immunopathologic features of lichen planus are non-specific. Most lesions show the deposition of a shaggy band of fibrinogen at the basement membrane zone. So here we can see a histopathological diagram of oral lichen planus. So hyperkeratosis is seen, civet bodies, band-like epithelium here is seen, and the retipex you can see are in the form are sawtooth shape. Next, coming to the differential diagnosis, oral lesions which bear superficial resemblance to lichen planus include leukocyte reactions, leukoplakia, candidiasis, pemphigus, trichadrial pemphigoid, erythema multiforme, syphilis, recurrent ephthai, and lupus erythematosus. So these are some of the disease which can be given for differential diagnosis of oral lichen planus. Then next, coming to the malignant transformation, there seems to be a slight higher incidence of oral squamous cell carcinoma in patients with oral lichen planus than in the general population. The actual overall frequency of malignant transformation is low, varying between 0.3 and 3%. The forms that more commonly undergo malignant transformation are the erosive and atrophic forms. Lastly, we come to the treatment. Medical treatment of oral lichen planus is essential for the management of painful, rhythmatous, erosive, or bullous lesions. The principal aim of current oral lichen planus therapy are the resolution of painful symptoms, the resolution of oral mucosal lesions, the reduction of the risk of oral cancer, and the maintenance of good oral hygiene. As it is an autoimmune mediated condition, corticosteroids are also recommended in patients with recurrent painful disease. Another goal is the prolongation of their symptom-free intervals. The main concern with the current therapies are the local and systemic adverse effects and lesion recurrence after treatment is withdrawn. Patients should be observed periodically, particularly those with the erosive or atrophic forms, and those also have a history of alcohol and tobacco misuse because of the risk of malignant transformation. So that was all for oral lichen planus. Thank you.